on this episode of A Tale of Two Hygienists.
If your child is snoring, if their mouth is open and they're breathing heavy, then they are breathing through the equivalent of a coffee straw. So a 7-year-old has a 7-millimeter airway. And if their tongue is not at the roof of their mouth, if it's, when we fall asleep, all of our muscles fall asleep. Well, your tongue is a big muscle. And if it's not trained to do the right thing during the day, it's not going to do the right thing at nighttime.
The benefits of breathing through your nose is really that you're getting, there's, I think they say 26 different processes that are actually happening through your nose when you breathe through your nose. But one of the big ones that we haven't really touched on yet is there's nitric oxide that's released when we breathe through our nose. And so that benefit of what nitric oxide does for us is a natural anti-inflammatory. So again, that's going to help reduce that upper respiratory inflammation that only gets aggravated when you actually breathe through your mouth.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 423. I'm your host, Andrew Johnston, and thank you so much for listening. And also, happy Chicago Midwinter Week for all of those who celebrate this joyous occasion. We have a great episode for you today, but before I talk about it, I want to give a huge shout out to the Chicago Dental Society. They are the best and most gracious hosts that this podcast has probably ever seen. They've been hosting us at the Chicago Midwinter Meeting since I want to say 2016, maybe. So I guess that makes this our 9th year of recording episodes there. My math might be faulty on that. But for those of you who have never been to a bigger conference, so I'm not talking about like your association conference or maybe your state conference. I'm talking about like a big giant regional conference, which I guess Chicago Midwinter is technically, I think, a city conference. Anyways, it's bigger than that. Everyone goes to it. If you haven't been before, I would say try make Chicago Midwinter like one of the next ones you go to. For hygienists, I've talked about this before, but the cost is super low and they have a bunch of free courses, which is really nice. But then they also have some courses that you pay for. The McCormick is a huge conference center and dental pretty much takes over the whole entire thing. Hotel prices are really reasonable. And since it's midwinter in Chicago, they have really great prices. They also have plenty of buses to get you around town. So one of the things I don't think people think about a lot is when you have these conferences and you have to get to and from the different events or the different hotels to the conferences or whatever, these bigger conferences often have kind of like a shuttle service through the bus system, not like the city bus, but like for the conference, the buses. And over the span of probably 3 or 4 days, that really does save quite a bit of money. I mean, it can save, probably up to $100 or $200 worth of like cab fares and things like that. So it really well done as far as that goes. It's just, everything's awesome. Networking events. There's so many networking events. I think most nights have probably at least 2 or 3 for most people to attend. So that's really cool. So if you're planning on making it out to a big conference in the next maybe 3 or 4 years, really start researching and giving Chicago Midwinter kind of the nod, if you will, because it's definitely one that has been just gracious enough to allow us to just set up shop wherever we can find place and, record. And, they never said boo about it. In fact, I think they've been really, really welcoming to us from the emails and the communications and all of that. So very thankful for that. All right. So in this episode, we continue on for part 3, which this is actually the 4th episode. So if you haven't listened to the other episodes, you don't have to before you listen to this one, but it's a good idea. So go back and listen to the last few. But in this 4th episode, it's now back to Leslie and Heidi and myself talking about myofunctional therapy. And this time we're going to be focusing on children. We cover a lot in this episode, but weirdly, it kind of just feels like the tip of the iceberg sometimes. We talk about assessments and tongue posture and function, airway, nasal breathing, nitric oxide, all of the keywords and terms that you'd expect from this type of a show. This is on this episode. You should go away from this episode feeling a lot more confident in the fact that you really do know what you're talking about. I think a lot of this is going to be reaffirming, but then there's going to be a little bit where it's like, oh, dang, you know what? I need to learn a little bit more. So make sure you're reaching out to both Heidi and or Leslie and see what next steps they might have for you. They're both a wealth of knowledge in this space, and they have a lot of connections, which you're finding out, I guess, over these last several episodes. And then next week, darn it, we finish our series, and I'm feeling really sad about that actually. But Heidi and Leslie brought with them next week on the episode a chiropractor, Dr. Andrea Smith, and she opens up just a whole new world to me. And this has happened several times on this podcast before. I've sounded really, really dumb. And it's just because these people that come on are just amazing. And I don't even know how to ask the questions. And so I kind of just go not really down rabbit holes, but kinda. You guys know how my brain works by now. But Dr. Smith was just awesome about it. And she was just very smart and intelligent and was able to bring me back to reality sometimes and connect what I was trying to say into something that is comprehensible. So I appreciate her for doing that. So if for nothing else, come back next week to listen to my ridiculousness. But if you want to come for an amazing conversation about really how everything is connected, you're probably not going to have a better episode than you will next week. So don't miss that one. Heidi and Leslie will be at Midwinter this week, everyone. So if you are in Chicago and you want to meet them, make sure you send them a quick note. Thanks again for listening and enjoy this episode.
A tale of two hygienists.
Welcome, everyone, into the interview portion of the podcast. I am joined again by Leslie and Heidi. Both of you, thank you so much. A little, I think we're going to blow people's minds, but guess what? We're recording on the same day as did the first one. But quote unquote, welcome back. But it's nice to see you 5 minutes ago, too.
Yeah.
It's always like the magic of podcasting is not really all that magical. So, anyways, I'm really excited.
I'm pretty mesmerized by it all.
It's cool, though. I'll be honest, it's not magical, but it's cool. We are going to talk today about children. I think that's like the main topic of today. It is one that I think definitely pediatric practices, heads up, pay attention to this, right? But your general practices, you're going to learn a lot of things here as well. I think we're going to talk a little bit about like ortho and stuff like that as well. I don't know any hygienist who has never seen an ortho patient. If you haven't, I mean, gold star to you and you're lucky because it is not always the funnest work, but welcome to the show. Thanks for coming back.
Yes, thanks for having us.
All right. So with children, is myofunctional therapy different with children as far as like the evaluation part of it, or is it kind of across the board? You're just doing the same evaluations for anyone, no matter what their stage of life?
I would say that the evaluation is similar. I feel like, children from a motor processing standpoint and things like that can sometimes be in a different space than our adult patients. So that's where you have to kind of figure out like, what can you do with this patient and how can you get them to engage in what you're actually trying to evaluate? So that's where kind of some of the difference comes into, but you're still screening and looking anatomically for the same type of features. It's just how you go about that process may look a little different.
And I really like to talk to the parents too, and just it's great if dental offices can just have a few questions on their medical history, that kind of give us a heads up. How does your child sleep? Are their sheets twisted? Are they bedwetting? Are they snoring? And I think those are things that we want to know just because they give us like some guidance of follow-up questions or things to look at when whether we see the patient in a clinical setting or via telehealth or however that works.
Does the telehealth aspect of it make it a little bit more difficult to see like the, you guys don't correct me, the shape and dimensions of the jaw and like the development of the jaw or things like that are maybe in person easier to, you can palpate it, you can see it, you can do all of these things?
Yes. I mean, obviously it's different when you're seeing any patient, whether it's an adult or a child via telehealth. One thing that we do is we send out a very comprehensive evaluation form to have them fill out prior to, and we send them a packet in the mail of stuff. And then we want them to take certain videos and photos for us prior to, and we walk them through some measurements that we need, for our assessments and stuff. So it's a little different, but we can still really get a good idea of what's going on.
Yeah, that assessment totally helps. But I also, when I work with telehealth patients too, I make sure that they kind of have the understanding that you need like a good quality camera to be doing, like the telehealth and lighting and those type of things that will make it a little bit easier to see inside their mouth while they're doing the work. So those are kind of the two approaches that we have to making sure it sets us up for a little more success when doing things through telehealth. Don't you think, Heidi?
Yes. And I like them to have a flashlight and a mirror available so they can actually see themselves. Sometimes the camera is hard So those are all things that we kind of prepare them for.
As far as like the importance level of like doing screenings and evaluations for children versus adults, is there a significant number of kind of abnormalities and problems that we're seeing in kids that maybe they grow out of as adults, or are we seeing more in adults? Kind of what's the importance factor level here?
It only progresses one way, unfortunately. It's only going to get worse. So for most, I mean, you can have,
well, unless there's intervention.
Yes. Right? That's what I mean. If there's no intervention, it's really only going one way. They say sleep apnea is really developed from childhood. And so a child, if they're a mouth breather, their chance of developing sleep apnea is I think the statistic is over 70% as an adult. And so, there's like, if you snore, so like our children should never snore. It's never okay, really as an adult or child. This is one thing that actually really, impacted me wanting to go into myofunctional therapy, because one of the courses I went to, over 10 years ago, my daughter was only a couple years old at the time. And she, as the speaker, it was a pediatric airway course. He's talking about all these symptoms that I am checking off, for my daughter. And she had low emotional resilience. She would have meltdowns at nighttime prior to going to bed, twisted sheets, all these different things, snoring, mouth breathing, and sleeping, not as during the day. And he said something very profound I will never forget. He said, how often is it okay for your child to not get enough oxygen at nighttime? Never. And if your child is snoring, if their mouth is open and they're breathing heavy, then they are breathing through the equivalent of a coffee straw. So a 7-year-old has a 7-millimeter airway. And if their tongue is not at the roof of their mouth, if it's, when we fall asleep, all of our muscles fall asleep. Well, your tongue is a big muscle. And if it's not trained to do the right thing during the day, it's not going to do the right thing at nighttime. And it's going to obstruct their airway. And so it has a bigger impact. So that is one thing I'd say to all parents. There's an app that you can download called Snore Lab. It's free. I have a lot of my clients do this and just record it. Even my adults who think that they don't snore or whatnot, it's like, record yourself for a few nights and see what's going on. And you can actually hear yourself on the app if there's, any heavy breathing or snoring happening.
I want to kind of get into this. We talked a lot about airway. We talked a lot about kind of these, snoring and whatever. We haven't really talked much about like speech issues and kind of speech impediments and things like that, because I feel like that is historically what we've like, oh, you have something wrong because your speech is off. Can we talk a little bit more about that?
Yeah, I think that, well, and again, Heidi and I aren't speech pathologists, so that's not like, speech is not exactly where we're trained. And that's why a lot of times when I see children, I am working in collaboration with speech pathologists too. But when we're looking at speech development, and again, kind of like we've touched on a couple of times now, but there's kind of two factors that we're really looking at. Is it more just low tongue tone, and so that they don't have that muscle built up in the coordination to it? Or is it more that there's something anatomical, which it's the physical restriction underneath their tongue, their inability to kind of move their tongue without using their jaw, different things like that can kind of impact where their tongue goes to be able to make different sounds. And so that's where, when we look at kind of the anterior portion of the tongue and the sound and la sound, things like that, where the tongue has to be able to go up behind those top front teeth. And then there's back of tongue sounds where you're making more the k sounds, the g sounds. Those are kind of things that we look at, just seeing like, where does a child's tongue go when they are trying to make those sounds? When you hear that lisp being, there's different types of lisps, the ones that come out the sides of the mouth, the one that comes out the front portion of the mouth. When you hear and see those in children, kind of wondering, well, what's actually happening inside their mouth, contributing to why that tends to be how their pronunciation comes out.
So with the lisp, as well, my daughter had a lisp, and it was a lateral lisp, and it was actually your tongue plays a key role in the formation of the jaw, but it also can play, how our bite comes together. And so it was actually creating an open bite laterally so that her teeth didn't actually touch there. And so again, it's really important to retrain that tongue with the swallow goes hand in hand with correcting the lisp, but also their swallow.
So is there ever a time when we have these kind of speech issues where it's lack of learning as opposed to like low muscle tone or kind of anatomical like tethers and ties? Is there ever just like they never learned how to do this thing and it's just they just need to be taught?
Yes, definitely. I mean, but I think that goes with when those muscles haven't learned the correct like movements and position of things, that's what then creates some of that low tone, is because they haven't actually been activating, the correct muscles to do that. So there's definitely like they didn't learn to do it correctly, but when they haven't learned to do it correctly and they've been making these adaptations and using other muscle groups, that's what creates that lower muscle tone in the muscle groups that we do want to be being used.
And it's never because the child is just like too lazy to say that the right way. Some of my
I haven't run into that yet.
I have it like clinically seen, but I tell it my kids sometimes like just say the word, just say it right. Like you guys can do this. You're just being lazy.
So I had a parent, actually, that's a really good point. I had a parent say to me one time, I don't understand when my child, when we're sitting here, they can say the word or they can do it correctly. But when they start talking, quickly and stuff, that's when they pronounce it wrong or whatnot. And I think that has to do with the tone, like Leslie was saying, that their tongue just gets tired. It's a muscle. Like we need to train it and work it out.
Interesting. Let's go into some of those trainings here in a few minutes because I'm very interested about like the push-ups for the tongue or whatever. I don't know. Like, they're doing barbells. I don't know what they're doing. But so we'll get into that in a few minutes. But I kind of want to talk, kind of circling back to like early interventions, long-term benefits, and kind of like those. By the way, you have an ortho link. I don't know what ortho link means, but that's kind of where I'm going with this.
Yeah. Well, that's the connection. I mean, really, like same thing. When I think children tend to be my passion because, again, I firsthand saw this in both of my daughters. And so it's not only, getting providers to understand the connection that this has to so much more, but just even like Heidi had mentioned previously too, but that time to like educate and talk to these parents and kind of hear about what they're dealing with and, how these connections actually go together so that it can help them have more success when they are going through different treatments with their child. And there's different aspects to that as well. So with the orthodontics, Heidi and I will often talk about, if you're going through orthodontic treatment, then really we think you should be having a myofunctional therapy consult as well, because it really does go hand in hand with the fact that if the growth is off in a child and we're saying, okay, their teeth are all crowded, well, then somewhere along there, the jaws didn't really get developed enough to actually make enough room for those teeth to come in the correct spacing. So, that goes hand in hand with if that jaw growth isn't there, what's contributing to that? Are the muscles not working in proper function? And if you're going through orthodontics and you're just mechanically kind of like expanding and you're putting a palate expander in there and it's applying pressure to be able to guide that growth of that upper jaw, well, if the tongue's not now trained to stay up there and kind of support that upper jaw, then we're going to tend to see that the muscles of the face and the lips that tend to do more retrusive pressures onto the face are going to tend to want to kind of collapse that right back in again. So, I think I tell every single one of my patients when I'm talking to them about the tongue, I kind of refer to it as the natural palate expander. Your tongue, if it's sitting up on the roof of your mouth and applying that pressure to your palate, we should be seeing this nice, broad, wide U-shape growth happen to the jaw.
So the thing about that, Leslie, though, I just feel like I've been told as a hygienist so many times that our tongue really is strong enough to kind of expand the palate. Like you're talking about this therapy that's going to help me kind of widen that palate. It's hard for me to believe because the without a palatal expander, like the constant pressure that it seems that it would take doesn't seem likely.
Well, and that's to say, and it depends on how long the function's been off to kind of have the lack of growth there in the upper jaw, right? So I'm not saying that the tongue being up there, if we're screening somebody at the age of 7, being like, okay, if you just do myofunctional therapy itself, now all of a sudden we're going to be able to gain 7 millimeters of palatal width that we've lost over the course of development of 7 years. But if you go into palate expansion and actually catch up on that growth that didn't idealize in those first 7 years of life, well then now if we actually start retraining the function so that once we have caught up on growth, the tongue's now supporting those arches to stay in that posture and not have that collapsibility. Like so much of the relapse that we see with orthodontics, like that's one big thing we talk about, is that a lot of that drives from not addressing that muscle function in the first place. So if we want to support that we've caught up on this growth, that tongue being up on the palate is a huge aspect of that.
Yeah, that makes a lot more sense. I think maybe I keep wanting to hear it wrong, but I've heard it wrong for so many years. So thank you for that clarification.
And I think part of that is going back again to the root cause of things. You know, when we go back to the root cause, like we're really good. And I wore a night guard for 20 years. So I loved my night guard, but a night guard is a Band-Aid, you know? And so I'm not saying that it is not helpful in certain cases. Yes, it helped me a lot for many years. I no longer wear a night guard because, again, going back to the root cause. So when we're treating someone that's going through orthodontics, we want to make sure that we're correcting the tongue posture, the muscle functions and stuff. So how many people do you know that have gone through orthodontics more than once because they have gotten relapse or open bites? That is a orthodontist's like worst nightmare. I had one of them tell me, like, you know, as he's treating this woman who's in her 20s, the third time, you know, she was trying to close that open bite, and, you know, he sent her to me and we corrected that tongue thrust. Your tongue is one of the most powerful muscles in your body. You know, it really is something that you need to train to work properly. And it's amazing when you do that. What I tell people is, yes, our 4 goals in myofunctional therapy are to get your tongue up to the proper position, get your nasal breathing, lips sealed, correct your swallow. But it has a domino effect in the body of what you see happen with digestion, allergies, asthma, anxiety, you know, jaw issues, headaches, all of these things. When you right those muscles and put things back to proper function, it's crazy what, you know, success we have with treating all of those things I just mentioned.
Let's go into maybe a step by step, because I feel like that's really helpful for the listeners. Okay, a child of whatever age you guys want to use as your example, you know, it's going to be in your chair. Start to kind of finish. How do you do the assessment? What are you looking for? Talk about the points when you're, you know, talking to a parent about something versus talking to a child about something, and then kind of what the follow-ups after that might look like.
Yeah. Why don't I start with kind of talking a little bit about just like appropriate screening questions is kind of what it really starts with when that patient's in your chair. So, you know, if we kind of start to see the growth and development off and we're looking more from, again, kind of the root cause standpoint, that's when I typically start asking parents questions about like, how does your child sleep? Like, does your child wake up in the middle of the night? And then also things about like their posture. Have you ever gone in at night when they're sleeping? Like, do you know if they sleep with their mouth open? Do they tend to have allergies? Are they chronically congested? And a lot of times when you start asking those questions, parents will be like, why are you asking me this? You know, they like are like, what are you seeing that's making you ask these things and know this about my child? And so then it kind of starts this bigger conversation of, okay, well, this is why I'm asking these things, is because we do see that, you know, say it be the growth and development, and we're noticing that this child has a very narrow palate that's bolted, that from the moment we went out and got them from the reception area, that they were walking around with their mouth more open, you know, kind of audible breathing. Like those are all things that really we're screening for the whole time that we're, you know, doing an evaluation on a child. So I think it really starts with kind of asking the appropriate questions to see, you know, are there some of these dots connecting for you? And then that warrants more of the conversation around, okay, now here's how we would actually do kind of a physical evaluation on the child.
Is this from like a checklist that you have chairside, or is this on a medical history? Like where are these questions in your like process of this?
Well, I no longer work in, you know, a dental practice, so I don't see patients clinically. So it's a referral from, you know, either a medical or dental provider who have seen things. So, but we do, again, want to help, you know, train. Every hygienist can screen, whether they're a myofunctional therapist or not. But it does start out with just some basic questions, you know, on the intake form or the medical history if they're an established patient. And then it's the hygienist just asking more like in-depth questions if they've said something like, yes, my child doesn't sleep or is a thumbsucker, or, you know, any of these things that might be an alert. Like we want to ask more about that. And then it's almost a referral.
So it's almost like almost like a flow chart, right? Like, so if yes, then here's like some more follow-up questions. If no, then move on to page 13 or whatever. I don't know.
So basically, what we don't want to put any more pressure on hygienists. We know that they are already doing so many things in the chair, but these are quick questions that they can ask. And again, then they can, like for like Leslie and I, for example, I used to do free, I still do. We offer free consults to parents or adults, that is just informational. I want them to have the information so they can start making some of these connections that they might not even realize are related to the airway, sleep, and breathing. We've now developed as part of our courses, we will have a video consultation. So dental offices could just send the patient home with this video to watch, at home. And then they could reach out and do a free 10 or 15 minute consultation with us to see if myofunctional therapy would be beneficial for them or their child.
Yeah. And I think going back to like your question too, there is the aspect of the screening questions to kind of ask whether you're a hygienist or not. But like once they actually have been referred and come to us, like, yes, we clearly have our information and kind of education that we want to just be providing to all of our patients and our parents out there.
So you have like the question, and then you have there's a physical part of it too. I feel like a lot of, we talked about it on an earlier episode about, with adults, you're going to see a lot of like musculature differences in the neck, but the child might not have those things yet. So are you jumping straight into the mouth? Are you still also looking for like extra oral, like musculature things? Are you looking for like bags under the eyes? Like what are you assessing for physically then as like a process?
The first thing I would look for is the kid's posture. I would look to see if they have a forward head or even tilting their head to the side. These can all be compensations. I would look to see how is that child developmentally looking overall. Because one thing, if children aren't getting the correct sleep cycles, they're not going to grow to their fullest potential either. My daughter was always like, and I remember when she was younger, she looked a couple years younger than her age because she was smaller. So these are things that we want to, again, look at. Do we want to look at under their eyes? Do they have dark circles? That again, it can be multiple things, but it can be that they're not getting the right sleep cycle. So oftentimes we hear, oh, my kid sleeps like, 10 hours a night. It doesn't matter how much you sleep if you are not getting the correct sleep cycles, whether you're a child or an adult. So because what happens is if that child is mouth breathing, their airway's getting obstructed. And so they can't get into that deep parasympathetic sleep, which is what we really need, those 4 or 5 cycles of that healing. It's, where all these major processes happen at nighttime. But if they're constantly struggling to breathe, they're getting pulled out of that parasympathetic and they're being put into fight or flight, which is basically a junk sleep. So you can sleep 10 hours, but if you're getting more junk sleep than anything, then you're going to feel exhausted. You're not going to, your emotional resilience is, going to be off. And again, developmentally, that has a huge impact on a child.
Yeah, it's really like the quality of the sleep, not, quantity as much. I mean, obviously there's certain hours we want you to reach of sleep, but you can, like Heidi mentioned, be sleeping 10 hours. But if it's just crap quality the whole night long, then that's not really, 10 hours of solid sleep.
All right. You ready for some secret time? And the editors can leave this part in. It's fine with me. So, we've talked a little bit off air. It's like, yeah, my sleep, and I think we said on one of the episodes, yeah, I don't sleep the best always, but generally I do okay. So I've noticed though, as the years have gone on, I've had like more pronounced bags under my eyes. Now I look at pictures of me and like as a kid, I kind of always have had bags under my eyes, like that kind of darkness. And so my wife and I decided we're going to do like an A/B test. Like we're going to put whatever that cream that people put on like at nighttime.
Yeah.
Okay. So we've been doing that now for, I don't know how long we've done it, 2 weeks, 3 weeks, whatever. She says it's supposed to take a month before we see any results. So this is the test that we're going to do. And our audio listeners aren't going to be able to, well, we don't have video listeners anyways, but our audio people are going to not be able to tell this. But I'm going to like hold my fingers like 1 and 2. I want you guys to tell me which eye you think that we put the eye serum on. Okay, hold on. I'll get closer to the screen.
I was going to say, you're going to have to get a little closer to the screen.
You put it under your right eye. Your right eye?
Which number is that?
Oh, 2.
Yeah. Well, hold on. You're pushing one up against your face right now. So it's going to make it look a little wrinkled. Okay. Yeah, I'll go to the other side. Yeah, I would agree too.
All right, that's a bunch of crap. How is that? How did you know that? What are you looking? What do you see? I don't see a difference, but it's incredible. Also, maybe the lights. Maybe the light's over here because you're seeing it better and there's just darkness over on.
No.
Really?
Yeah. So
Oh, I might have to start doing some cream on my eyes.
you know what's interesting, kind of on this
Do we need
subject,
to put a little plug in for whatever cream you're using right now?
right?
Yeah, you think I would know what that is? No, it's funny. 'Cause she's like, she'll come up to me, like she does her like 19 routine or whatever, and guys don't do that, right? But she's like, okay, and she like dabs it, and she's like, you're supposed to dab, you're not supposed to like smush. I'm like, okay. So,
No, it's definitely, I can definitely tell.
she's gonna love to hear this.
Yes.
All right, let's get back on track to the podcast. We're talking about bags under the eyes for children, and kind of the what you're looking for, and I just kind of wanted to see if like you guys could do that.
Well, and to kind of talk to that a little bit, Andrew, though, like the reason we look for bags under the eyes, obviously, yes, like we think of bags under the eyes when somebody looks tired, but like the technical term for that is kind of venous pooling. Like it's also a sign that there's inflammation and not proper drainage from the sinuses happening at that point too. So there's like more to what that actually is that we look for, and same thing with us.
So it's not just sleep then at that point though. Like right, if you're having like drainage issues, then there's like constriction or construction. Obstruction up there.
Yeah.
And I think one thing you talked about mouth breathing earlier, you asked me about it. And when you mouth breathe, you're getting unsterilized, unfiltered air. And so nasal breathing, it sterilizes and filters everything. We were designed to only nasal breathe. Your mouth should only be used as a 911 backup. But what happens is when you start mouth breathing, you could say when you were little, maybe get a really bad cold and you started mouth breathing and you just never went back to nasal breathing afterwards because it became a habit. Well, what happens is your tonsils and adenoids, as we talked about earlier, can get inflamed. You can develop more sickness, like more allergies, nasal congestion. So then it makes it even harder for you to breathe through your nose.
Yeah, because the benefits of breathing through your nose is really that you're getting, there's, I think they say 26 different processes that are actually happening through your nose when you breathe through your nose. But one of the big ones that we haven't really touched on yet is there's nitric oxide that's released when we breathe through our nose. And so that benefit of what nitric oxide does for us is a natural anti-inflammatory. So again, that's going to help reduce that upper respiratory inflammation that only gets aggravated when you actually breathe through your mouth. So we want to breathe through the nose so that we get kind of that reduction of that inflammation, but then also the benefit that nitric oxide does for as it goes into our body and kind of attaching to oxygen in the cells, and the benefit that does for our whole entire body. There really is such benefits to breathing through your nose.
Can we talk a little bit about like the oral habits, the things that you kind of typically think of like little kids, okay, they're finger or thumb suckers or things like that, and kind of what impact that could have kind of later on in their development, ortho and all that?
It's huge, because if your thumb or your finger or a blanket or anything is in your mouth, then your tongue is not in the proper position. It's taking place of, that tongue being where it should be. So it also creates pressure. So what we see with kids who, are thumb suckers is that they're going to have a high vaulted palate, so the roof of their mouth is going to, everything kind of collapses. And again, you want to think of this, the roof of your mouth is the floor of your nasal cavity. And so if the roof of your mouth is narrow, then that means your nasal cavity is also narrow. So we really want to prevent and get rid of these habits as early on as we can. But it's also important to get kids chewing. Again, kind of going back to the root cause, we need to, the book Breath is amazing. It talks, about the research and how 400 years ago, things really started changing with the way we eat, and how that has really had an effect on our facial features and the growth and development of things. And so again, getting kids to chew on things and develop, it helps develop the bone, and the midline suture kind of helps with that growth and development too. So again, all these factors play a huge role.
Do you feel?
Which I think, like, back to being a mom, and like before I knew some of the things that I know now, and not to say like, again, we have to do what we have to do as moms sometimes, but like the pouches that we feed our kids, so we're not making our kids have to like chew their food as much anymore. And so there's a lot to that baby-led weaning, to kind of changing the fact that we actually are chewing and using those jaws. The more you actually are engaging that jaw movement, that's what's helping stimulate the bone and the bone growth there.
I mean, I remember just like I just don't want to say craze, but like our kids don't know how to eat. They're going to choke on their own food was like the biggest, scariest thing as a young parent. You know, we were really young parents. And so like, we fed into everything that people told us. And so, yeah, the pouches were one, it's convenient, right? But it was also like, they're going to get their nutrition, they're going to do this, and they won't die. Like there's no middle ground. Like they're going to die if they have this grape, you know, like it's such a bad thing.
I think choking was one of my biggest fears as a parent. So even like for food, it was like chopping your food up as small as possible. Things like that. Where now, you know, there's a very different philosophy towards that. And, you know, how those changes though of like the pouches and all this soft food and processed food and all this are not making us have to do as much chewing and work, you know, to our jaws.
It's so weird how like quickly, I mean, in our lifetime, you know, growing up as a child, we never had pouches. That wasn't a thing growing up.
Right.
And then just all of a sudden this all exists. And now we're already flipping back to be like, oh, holy crap, guys, like we're too far in. Like we need to about face, and all within 30 years. Like that's pretty fast, I think, as far as movement goes. But I want to come back to like the thumb sucking thing, because I don't know why this popped in my head, but I was thinking, you know, I had heard at one point, I think that it's pretty solid. A lot of times when we were clenching and grinding in our sleep, it's because we have, you know, bad airway issues. And it's kind of like a micro like movement to help us like awaken up enough so we can get a gulp of air or whatever. Is there any benefit to like I'm thinking like airway or anything else, like where they're, you know, using their thumb to open up an airway, or they're doing something to help themselves, which is actually causing more problem? But is that why they're doing these habits, or is it really just the fact that it's just a weird habit?
No, a lot of times there is an airway connection to it.
And I agree. And part of it too, if that tongue, so there is a connection with your tongue and being at the roof of your mouth and putting you more into a parasympathetic phase. And so I don't know if there's really any research, but I know when I've been working with my osteopathic doctors and stuff, we have talked about this. Is it, you know, I think people say thumb sucking soothes the child. And are they doing that because their tongue isn't up there to soothe them? So they're putting something up there to kind of like self-soothe them, you know? So that's why we see a lot of kids, I think, you know, doing it when they, you know, go to bed, because that tongue, if that tongue was up there, that would kind of put them more into a parasympathetic, you know, phase.
And then there's another part that, to like you were kind of saying, as a protective mechanism of the airway too. If you kind of think about when the thumb is actually placed in the mouth, the jaw tends to come slightly more forward in its like position there. And so I know I worked with a doctor once who was kind of explaining to me that it's almost like the child's way of having like a night guard or an ortho. It's actually kind of bringing that, you know, posture of the lower jaw forward, bringing the tongue forward to help that airway too. So sometimes it's because they recognize I can breathe better when my thumb's in my mouth too, because, you know, it's pulling tissue more forward out of that airway.
Oh, for sure. For sure. Look, we are running short on time yet again. This is always just so fascinating. I love these kinds of conversations, especially kind of helping our children, like the next generation. Closing thoughts and comments about kind of like children, airway, ortho, myofunctional therapy, all of this stuff.
I just think it's something that's really important. If, again, getting the education out there, doing these screenings, you know, whether it's at a dental office or it's the pediatrics, you know, doing it. I think our children are so precious. We can really set them up for a really different quality of life than maybe what we experienced. You know, we don't want our children to go through what we went through. We want them to thrive. And so I would encourage, you know, any dental professional that wants to know more, you know, reach out to Leslie and I, go to our website. It's coming soon. You know, we want to help people. We want to help you establish this in your offices. We want you to help your patients and stuff. And we're a resource.
And I think too, which Heidi and I have talked about so much before, but like we're saying, like our children, and just there's so much to how passionate we are about getting this education out about the children so that they don't grow into the adults that have all of these symptoms and issues. And I don't think that has to stop just at dental professionals and medical professionals. I mean, we've talked about like, how do we go in and even educate, you know, daycare providers for when they're screening at nap time and they're seeing this in the children, you know, from, you know, same thing, teachers who are with our children for, you know, multiple hours a day and have sometimes more an assessment on this kid's just mouth open all day long while they're trying to do their work. You know, there's it's powerful for anybody to have this knowledge and really start to be assessing these things, because it can make such an impact on quality of life if we can kind of recognize those things early enough in our children to change their course.
Gosh, that's power. I didn't even think we should have talked about that more, about all these other adults in our children's lives that need to be taught and can be advocates, kind of help us like co-manage these issues and be like kind of early adopters of change and things like that. People are going to have questions for you. I'm very sure of it. What's the best way to contact you?
So you can go to our website. It's myo2health.com, or you can reach out to us via email. It's info@myo2health.com, or you can use Heidi or Leslie at myo2health.com. I did want to make a quick plug, if I could, Andrew.
Always.
There's a YouTube video that I feel like every parent and provider should look at. It's very touching. I have a hard time not crying when I watch it. It's called Finding Connor Deegan, and it's a mother and her journey with her son who was diagnosed with oppositional defiant disorder and struggled in school and at home. And his doctor told him he should go, told the mom that she should talk to her dentist, who is in airway and doing a study and stuff. And it changed this young man's life. And, I think it's very touching on how much an impact we have in the dental world on our children. So I would recommend everyone to go see that.
Absolutely. I'll put it in the show notes too, listeners. If you can't remember the name, if you're driving or doing whatever, just click through. There'll be a link for you to that one. Thank you both for being here so much.
Thank you for having
Thank you.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.